All right, well, good afternoon, everyone, and welcome to the Friday session on future pandemics for the Isaac Newton Institute for Mathematical Sciences. And the theme this afternoon is on the wider context. I actually realize it's not this afternoon everywhere. The theme of this session is the wider context. You can deposit your Q&A, your questions through Slido, and I think the details of that have been made available. And we're going to start off with a talk by Christopher Dye from the University of Oxford. So I'll hand it over to Chris.
Thanks very much, Jess. Hello, everyone. I'm just going to take a moment to share my screen. Okay, so as Jess said, the theme of the discussion this afternoon is the wider context. And for me, the wider context is prevention in public health, of which stopping pandemics is one example. The general question, the age-old question is, if prevention is better than cure, why do we invest so little money in it? And I've thought about this in a wide range of contexts. I'll focus on pandemics today, but let me just give you a little bit of background to that. Here's one of the things that bothered me for years and years in public health. On the left-hand side, you see an archaeological site, a dig site in the Indus Valley, an excavation from about 2000 BC. And what you're looking at is a community-based sanitation system. So 2000 BC, Indus Valley, they not only knew how to do sanitation, but they also knew how to do socially community-based sanitation as well. And yet, the picture on the right, 4,000 years later, this is nearby India, somewhere around today, is a picture of open defecation, which is widespread in South Asia and Africa. So 4,000 years on, we knew how to do sanitation, and yet we still have a world in which 4.5 billion people don't have access to safe sanitation, and around about 5 million children die each year through preventable diseases associated with diarrhea linked to the failure of sanitation. So this is failure of prevention on a massive scale. And the question we need to ask is why does this happen? Here's a general presentation of the prevention problem. It's often characterized in this way. It's not actually precisely accurate, but it makes the point quite nicely. Around about $7 trillion is spent on health each year. So that's about $1,000 per person in the world. And of that 7 trillion, about 4% is spent on prevention and around 96% on clinical and hospital treatment. And that's despite the fact that you see on the left-hand side of this slide that many more deaths are from preventable causes, and they're classified on the left from environmental causes, at least 17%, metabolic diseases like diabetes, at least 30%, and then behavioral phenomena, at least 40%. And I've put behavior there in inverted commas because the mistake that's commonly made here is that the behavior refers to what people like the man in the picture do, which is smoking, and the behavior is attributable to smokers who are at risk of lung cancer. But public health is a collective venture, so the behavior we have to consider is not only those who are at risk, but governments, private businesses, financiers, and everybody else who have a stake in the outcome, and I'll come back to that theme. But the basic message is massive amounts of money spent on health, very tiny proportions of it devoted to prevention. So here, there are many, many, many examples. There are thousands of years worth examples, but here's just one recent one. This is the title of a green paper produced by the UK government. That's the smiling face of Matt Hancock, the current health secretary in the UK. Prevention is better than cure. It's a rather nicely written paper that goes with it. But of course, if politicians do one thing and say another, then trust in the idea that they will really invest in prevention is seriously eroded. And we have rather, well, considerable doubts about the UK government's intention to invest more in prevention at the moment, based on the record of the last 10 years. But what does prevention is better than cure actually mean? Well, broadly, two things. One is the aspirational idea, and that's the WHO highest attainable standard of health that you can read in the WHO Constitution. And that's all well and good. That's fine. That's nice to have in a document like the WHO Constitution. But what we should really be concerned about is how people make choices about prevention and cure, whether one is better than the other. And there I refer to the bottom part of the slide, which is more important. The fact is that prevention is not cost-free. It comes with a cost. And therefore, when people consider whether or not prevention is better than cure, they consider what it's going to cost them and what the benefits are that they can derive from it. And so my approach to investing this is essentially about cost-benefit analysis, or more broadly, cost-utility analysis. And the key elements of it are here. So prevention is more likely to be favoured if we have a hazard, a large hazard, which is avoidable, where the risk of that hazard actually taking place, the probability that an event will happen is high, and we can remove that, or we can lower that probability. And that if by doing that, we'll get a result soon rather than later. We like the present, we don't like the future, we're not much interested in the future. So hazard, risk, and timing or proximity are important. And of course, what it will cost, and there are really two elements to cost. There's how much you spend on it and the efficacy of your intervention. And putting those things together, the third section of this slide, what we're trying to do is do something like maximize the ratio of benefit to cost by including those key ingredients: hazard, risk, time discounting, cost, and efficacy. And those are the elements that you see in that formula. I've expressed it as a ratio of benefit to cost, but it won't always be a ratio, because under many circumstances, the absolute cost or the absolute benefit might be important too. But that's the general idea. So 3 points at the bottom of this slide to say about this before I proceed. First of all, this is not intended to be a statement of the truth. This is rather intended to be a testable hypothesis. It's a way of thinking about the problem, and it's a way of starting on the problem. The second point is that largely we won't be considering prevention versus cure in isolation. It will have a comparative aspect. In other words, if we're investing money in prevention, we have the option of investing it in something else, and we will usually be considering what that something else is. But the third thing right at the bottom of the slide is something I want to spend a little bit more time on, and that is values. Because the way in which people really make decisions depends on the facts of the kind that are laid out on this slide, but also the way in which they interpret those facts. And let me give you some examples. I've pulled together some well understood, I think reasonably well understood now, circumstances under which perceptions of risk, timing, and hazard vary according to what the nature of the risk or the hazard is. Under some circumstances, people give those risks or hazards higher values and sometimes lower values, irrespective of what they absolutely are. Some things are rated higher and some things are rated lower. So if you take on the right-hand side, an uncontrollable risk tends to be given a disproportionately high value. And the classic example here is aeroplane accidents. People don't want to die in aeroplanes. They're frightened of flying because, or partly because, they have no control over the outcome. And if an accident happens, they're very likely to die in that accident. And the consequence of that overvaluing risk, is that airplane travel is extremely safe. And that, of course, is, and the consequences for an airplane crash are grave. And that, of course, is the hole that Boeing is trying to dig themselves out at the moment. If aircraft companies make mistakes, then they are heavily punished. Flying is very safe. In the middle of the slide, I've already referred to time, which more generally is about proximity. We are bothered about things that happen very close to us today or tomorrow. We're much less bothered about things that are going to happen in the distant future. And that's why discounting is commonly used in in economic analyses of public health interventions. But moving to the bottom of this slide on hazard, you pick one example which is dreaded. People overrate the risks of dying from things that they greatly fear. A classic example is shark attack, which is seriously overestimated. The chance of that happening is seriously overestimated, but will apply also to some of the diseases that I'm going to talk about later in this talk. So the general point about this slide is that with respect to risk, timing, and hazard, we have to consider not only the measured values of risk, objective values of risk, and the impact of the hazard. We have to consider what people think about those risks, because that's how they make choices. Now, none of this is new. It's at least 300 years old. And here's an example of a discussion that happened around the development of decision theory and probability theory, which poses a problem that I'll leave you with. The Bernoulli family were involved, a family of overachievers. And actually, this is a problem that Nicholas Bernoulli posed to his cousin Daniel. And Daniel wrote down the answer to the problem and then suggested that they have a problem. And for the last 300 years, people have been talking about how to resolve that problem. And it's called the St. Petersburg paradox. St. Petersburg because that's the home of the journal where Bernoulli published his result. And the problem goes like this. I'm going to play a game. I'm going to toss a coin. And if I toss the coin and it comes up heads once, I will pay you twice what you have invested in joining the game. If it comes up heads twice consecutively, I'll pay you 4 times what you invested in the game. If it comes up heads 3 times consecutively, I'll pay you 8 times what you invested, and so on and so on. And what Bernoulli recognized is that if you add up the expected value, it approaches infinity on the right-hand side of the slide. In other words, the payoff is going to be very large, and you should be prepared to pay a large amount of money to join the game. But if you ask people how much are they willing to pay to join a game like that, they give answers which are substantially lower than infinity. So I'll leave you with that question. If you're invited to play the game, how much would you be willing to pay to join it? Now, irrespective of the mathematics, Gabriel Kramer, who was a correspondent at the time, really nailed it in words. He said, mathematicians estimate money in proportion to its quantity, and men of good sense in proportion to the usage that they make of it. Now, he said men because they were all men, of course, but also women knew all this already, so they didn't need to be told. But the problem has been a problem that's been long discussed. It's essentially a problem of utility theory. It's essentially a problem of the way in which you assign value, irrespective of expected outcomes. So let me come now to preventing pandemics, and I'll start with this quote here, which illustrates the problem that we are dealing with, that we're having to face in a number of ways. So this is from a well-known commentator in public health, published in Foreign Policy, actually just before the COVID outbreak, so it could be thought to be prescient. The comment is, the world knows an apocalyptic pandemic is coming, but nobody is interested in doing anything about it. Now, the tone of this is such that it suggests that it's obvious that this is going to happen, and when it does happen, I'm going to say, I told you so. But the approach I want to take, clearly, is to investigate why people don't do anything in the face of the threat of an apocalyptic pandemic. So let me examine that in 3 ways with respect to hazard, risk, and time. And the general problem is going to be that the perceived hazard is low, the risk is low, and the timing is remote. It's sometime in the future, we don't know when it is, and we're likely to devalue it. And I'll start with Ebola. I'll start with the Ebola outbreak in West Africa that I was heavily involved with at the time. And I want to consider in this first slide the way in which a pandemic of Ebola is evaluated against another pandemic, that of tuberculosis. So the relevant statistics are costs and deaths on this slide. And the point is that the cost of managing the Ebola epidemic in West Africa is about the same as managing the tuberculosis epidemic globally, around about $6 billion. And the economic costs of both of them, Ebola in West Africa, tuberculosis worldwide, are about the same too, around about $50 billion. There were around 10,000 deaths of Ebola in West Africa, around 10,000 TB deaths in West Africa, but about 1.3 million deaths from tuberculosis worldwide. So the amount of money that the world was willing to spend on Ebola was far, far greater than the amount of money the world was willing to spend on tuberculosis, because Ebola was a much more frightening hazard. It's the way in which people die of Ebola is really unpleasant. It's a hemorrhagic disease. The outbreak in West Africa was the largest that had ever occurred. It happened in a place where it wasn't expected to happen, and the future trajectory of the epidemic was really unclear. That's what brought in the money, the scariness of the disease, the uncertainty of the hazard. And many hazards, which are outbreaks of infectious diseases, have that in their favor, if you like. They stimulate a very strong response. The response to Ebola was so strong, in fact, that the army was involved, principally the US Army and the UK Army, the US Army in all three countries, mainly Liberia, but all three countries that were affected. The UK Army, principally in Sierra Leone, where I took these photographs. And when the army get involved, then the amount of investment goes up massively. And that was actually a key to controlling the Ebola outbreak in West Africa. The army, if you want to do logistics, then ask the army. Don't ask the public health people, who are much less good at it. The army and the World Food Programme together were the ones that played huge roles logistically in managing the Ebola outbreak, supporting local people on the ground. But that interest in Ebola was relatively short-lived. This, of course, is another problem in sustaining support. So what you see in this picture here is the levels of investment and how long they lasted. So the amount of money that was pledged was about $9 billion. About $6 billion was dispersed, as I showed on the previous slide. But most of the money that was dispersed was really in managing the problem as it existed, when it existed on the ground. And that's the two left columns on this picture, where the amount dispersed and the amount pledged are roughly the same. But once the problem was brought under control, the perception of Ebola as a hazard in and out of Africa, but particularly out of Africa to the rest of the world, subsided. And then the world was substantially less concerned about managing Ebola in West Africa, or indeed any other part of Africa. And so the central columns on this picture, the investment in recovery, there's a huge difference between what was pledged and what was dispersed. And on the right-hand side of this picture, the investment at the time in R&D was pitifully small. Now, I followed up very recently on investment in R&D for Ebola. In fact, in this rather nice report from GFinder, which was published a couple of days ago, you see Ebola is at the bottom of this slide, where you see, I'm moving around the covering picture. Ebola, you can see that from the little bar chart at the bottom here, R&D funds increased during the course of the epidemic in West Africa, and then they substantially subsided. For Zika virus, which was the pandemic, the public health emergency that followed Ebola, Zika funding, well, Zika was a new pandemic altogether. Zika funding increased enormously. But the thing I really want to draw your attention to is disease X in the top right-hand corner of this file. Disease X is the term given by WHO to any infection, any emerging infection, unknown, which could arise at any time in the world. And the encouraging signs in the top right-hand side of this slide is that there's been huge investment in disease X and other funding. And I want to say a little bit more about that now under the second heading, which is how we manage risk. The problem with risk is that if you consider each infection on its own, the risk will seem relatively small and relatively remote, and the hazard will seem small too. But if you can think about risks collectively, the problem becomes larger, and it becomes a problem that is susceptible to or attractive to a great deal of investment. So this is WHO's list of priority diseases for emergent diseases for R&D. It's a list of about 10. COVID-19 is, of course, at the top of this list, but at the bottom of this list is disease X. And I want to say a little bit more about disease X with respect to the logic of investing in pandemic prevention. So this is a graph produced by WHO, which maps 1,500 epidemic events. Sorry. Maps 1,500 epidemic events between 2011 and 2018 in 172 countries. Now, the point is for each of these outbreaks, any of them on their own would be unpredictable, but when you put them all together, they turn out to be highly predictable. Of course, we don't know which ones are going to be dominant, but if you look at the text below South Africa here, you see the advantage of bringing all the data together. So what's remarkable about these data is that within those 1,500 epidemic events, there's a very narrow range of number of events that arise per year, somewhere between 150 and 213. Those are the minimum and maximum number of events per year. So about 200 events per year. So ranging from avian influenza to Zika. So it's pretty clear that by adding all of these different threats together, we have a much more predictable environment for responding to outbreaks. I've titled this All the Eggs in One Basket. Of course, the implication of that is that if you pool your assets, that's a risky thing to do. When you pool your hazards and you share the costs, that's what we call insurance, and that's a sensible way of devising a policy for response. So I want to look at how that works in a little bit more detail, focusing on vaccines, a topic of the moment, but beginning with the development of the Ebola vaccine in West Africa. This took place, this was based on a precursor vaccine, which had been around for a decade or so, but not taken to conclusion because there wasn't sufficient enthusiasm for investing in that. Ebola was not seen to be important enough. But the vaccine was taken to conclusion with phase 3 trials that were done during the course of the epidemic itself. And the conversation during the course of the West Africa epidemic and immediately afterwards was, given the success of the vaccine, and it was an efficacious vaccine, and it has now been licensed. In fact, it was licensed in 2019. It took a few years to do it, but it is licensed. It was used under emergency use at the time. But the conversation was, why don't we build a system where we'll be able to anticipate much better than we did during Ebola of what kind of infection is going to emerge and how we can more quickly respond to that. And that discussion led to the foundation of a number of different initiatives, but one of them was Sept, which is a collaboration of investors who get together to do essentially three things: build a portfolio of precursor vaccines and actual vaccines against not single infections, but a portfolio of different hazards, guided by WHO's list: MERS, Lassa, Nipah, Rift Valley fever, chikungunya, Ebola, and so forth. In bringing together a group of generic technologies for rapid vaccine development with the idea of disease X in mind, we don't know what it's going to be, so let's build a platform or a precursor which will allow us to adapt quickly to whatever hazard emerges. And it was also a forum for risk sharing among investors. In other words, as they say in their own headline, a global insurance policy to defend against future epidemics. So by building coalitions of this kind, by using the idea of dealing with not individual, small and uncertain risks and pooling them as large threats or large risks and sharing investment with precursor platforms, we're in a much stronger position to respond to future pandemics. This is an elaboration of how that might be done, built on platform, so-called platform technologies. The graphic on the right-hand side shows rather simply what's intended. So the epidemic is in the top. What normally happens going down below is the reactive approach, where you go through all the stages of developing a vaccine or a drug or a diagnostic or whatever it may be while the epidemic is unfolding. But what we should really do is move leftwards and do all of those things in advance, building those platforms so that they can be readily adapted. So one of the best examples is the PIP framework, the Pandemic Influenza Preparedness Framework, but similar frameworks and platforms are now being developed for coronavirus, of course. So just a few words about coronavirus, since this is happening in front of our eyes at the moment. There are broadly two responses, as you will know from what's going on in the literature and what's going on in the news as well. There's the vaccine nationalism approach. We could characterize it like that on the left-hand side, or the vaccine equity approach on the right-hand side. WHO, Gavi, Sept, and other similar organizations have been keen on the vaccine equity approach, which is called COVAX. And the difference between the two is essentially vaccine nationalism is you place your bets, you decide what you're going to invest in, you choose your vaccine, you buy advanced doses even though you don't know it's going to work. In contrast, on the right-hand side, you can aim for an insurance policy, a vaccine equity policy. You can invest in a diverse portfolio of vaccines, so we don't know which one's going to work, but if you've got all of them in your portfolio, then you're more likely to have a successful outcome. About 170 countries have signed up to this. With regard to vaccine dispersal, the target is to make vaccine when it becomes available to 92 lower and middle income countries. And of course, with that amount of investment, then one can set favorable prices as well. In contrast, on the left-hand side, you have the UK that has bought, we hear, 340 million doses of vaccine from 6 different companies, the EU, 2.4 billion euros from one company, and the US, similar to the UK, 800 million doses from 6 companies. So that's really gambling in the casino on the left-hand side. So in principle, it's a great idea. In practice, and this, unfortunately, it's not getting the investment that it needs so far. The announcement that I just read from, actually from Jeremy Farr this morning, reported by Stat, is that COVAX has less than 10% of the funds that it's needed. So on paper, it's a good idea. It's encouraging investment, but it's not getting all the investment that it needs at the moment. Let me talk about one other idea for insurance, which promised great things, but which hasn't succeeded. And this is not to say that these things shouldn't be tried. I think they very much should be tried. But these insurance mechanisms, this demonstrates, have been hard to build. So this leads into what's been called the World Bank's Pandemic Finance Facility, which has its roots in attempting to insure against catastrophes such as hurricanes. And the stimulus for this was once again as applied to infectious diseases, was once again the West African Ebola outbreak. But this initiative, the Pandemic Finance Facility, has not performed well on Ebola, and it's not performed well on COVID either, and is now essentially dead in the view of all commentators and probably in the view of the World Bank as well. And there are broadly two problems, two lessons that have been learned from this, if such an insurance mechanism is going to be developed again in future. One is that what was required for a payout was a trigger mechanism, and the trigger mechanism required cases and deaths already to start happening in a country under emergency. And so the criticism that's been leveled at this is essentially the trigger mechanism is simply a way of waiting for people to die. What's needed is a mechanism where, when there's an outbreak, there's an instant payout, not a series of complex criteria in order to deliver the money. The other big criticism is that this was a mechanism steered by the World Bank. WHO collaborated in it, and I was partly involved at the WHO end. But the power was with the investors, particularly the insurance and reinsurance companies, who were not going to lose out of this. And the payouts that were given were much more favorable to the investors than to the people who were at risk. So there are ways, the message from this is that there are ways to build insurance mechanisms which will work, and there are ways to build insurance mechanisms that are less likely to work. And this was one that was less likely to work, and it holds some lessons for the future. I'll just briefly touch on one other insurance mechanism, the international health regulations. The IHR are actually much more than an insurance mechanism, but they do serve in that form, or they are intended to serve in that form. The idea is that if a country has an outbreak or any other health-related event of international importance, it reports it to the World Health Organization, and in return for reporting it, it will get international assistance, technical assistance, funds, and so forth. But the countries, in deciding whether to report or not, are always weighing up the costs and benefits. And if they feel that the threat is not likely to go international, or if they feel that the threat, announcing the threat to the world, has major economic consequences, then they are disinclined to do so. And that's been a bugbear of the international health regulations all along. And COVID has put the IHR to a test once again as a pandemic prevention mechanism. And there is active discussion once again about how IHR can be reformulated to be more effective. And that's not going to be an easy discussion. Let me finally come to timing. As I said at the beginning, we're much more concerned about, if we're going to invest in preventing pandemics, we want rapid payoffs. It's hard, as I've said, to predict which infection is going to cause the next pandemic or the next epidemic. It's substantially easier, however, to put in place a surveillance system which will identify unusual events that could be the start of a pandemic and then respond rapidly to those events. So this is an example of Ebola in Liberia. This was run by Liberia in conjunction with the CDC. It's called the RIGHT method, and RIGHT, the R stands for rapid and the E stands for epidemic, and it worked well for Ebola in Liberia in that setting. The rapid response mechanism that was invested in and set up built on health services that already exist. It cut the time to alert, it cut the duration of outbreaks, it shortened the number of generations of cases, in other words, the reproduction number. More patients were isolated, more were lab confirmed, and the case fatality rate went down as well. And the beauty of a system like that is that it delivers results rapidly, so people are willing or inclined to invest in it. And at the same time, it builds a generic system that supports health services. So that clearly is a way to go as well. And there are many other applications of this, many other versions of it that could be applied elsewhere. So let me finish with this quotation that comes from Michael Leavitt, who was US Secretary of Health and Human Services in 2007. He remarked that everything we do before a pandemic will seem alarmist. Everything we do after a pandemic will seem inadequate. Well, there are two kinds of frustration there, but the contention I make in this presentation is that if we take time to think about the nature of hazards, risks, timing, proximity, and costs, and so on, and not only in objective terms, but the way in which those who make the choices evaluate the information that they have before them, then both of those frustrations will be minimized. So thanks very much for listening. I have, if there's time to respond to it, another slide on the St. Petersburg paradox, but we can come back to the end, at the end if necessary. Thanks for listening. Back to you.
Well, that was fantastic, Chris. I think there's actually plenty of time, so I'd love to hear about the St. Peter's paradox, if that was okay.
Well, you tell me first of all how much you'd be willing to pay to play the game.
More details? Do I get more details? $10.
$10.
Mm-hmm.
Well, let me show you that last slide if I can. I have to share my screen again. Share. Okay. I wanted to share the slide I'm actually showing. Can you see that?
Mm-hmm. Yeah.
panel is in the way of it. So let me just leave it like that. So I think the problem with the problem as presented by Bernoulli and others is that it emphasizes what you will win from your investment and that the winnings are very, very large. But I think what's important to many people is how much they're going to lose. How much can you afford to lose? So anytime you make a bet, I mean, nobody thinks they're actually going to get very far in this game. So what I've illustrated on this slide here is that if you succeed in getting 6 heads in a row and you investigate $1, and then at the 7th toss of the coin, it comes up tails rather than heads, then what you've got is an 84% chance of losing your original dollar that you invested and a 16% chance of winning $64 under those circumstances. And I think the question many people will ask, among others, is what can I afford to lose on this game? So the answer typically, apparently others who have done surveys, I haven't, but the others that have done surveys say that most people wouldn't go above about $25 to pay a game like this. And how much you would be willing to pay, of course, depends on how much money you've got. How much can you afford to lose? But that's the point about utility, is that in cost-benefit analysis, people are going to consider what are the costs and benefits, not just in objective terms, but what is the value of those costs and benefits to me in particular? And what's important in understanding how people make choices in public health or anything else is to understand not only what the facts are about the risks, but how people value those facts with respect to the risks. And that's essentially cost utility analysis. And Bernoulli and Kramer and others were basically the founding fathers of that. And the exploration of utility analysis has gone on for hundreds of years since. But what I will just add is that that body of analysis in public health is exploited in a very narrow way. So in informal cost utility analysis, as is expressed in health economics textbooks, you'll see cost of expenditure in relation to DALYs and so on. And that's useful for advice for governments who are saying, shall we provide this drug or that drug through a health service? But in general, it's not useful for understanding how people make choices in public health in general, because that requires an understanding not just of what governments might be willing to do, but what individual players are willing to do and what businesses are willing to do as well. So you have to know what values are attached by all the people who are involved in making the decisions. That's the broader point that comes from that coin tossing game.
That's fascinating. So I'm going to encourage anyone to do submit your questions to Slido or share them more generally. But Chris, I'm also, I feel like what you're pointing to is there is quite a lot of research sort of at the interface of psychology and economics on things like loss aversion and this sort of thing. Are you sort of saying that we should be reaching across the aisle more and reaching for more discussion there? Are there clear research directions that need to
Absolutely.
be
Yeah, absolutely. I think it's fundamental. If you want to understand how people make choices, then that literature on behavior and psychology has to be brought into traditional health economics. And I think it's done rather poorly at the moment. And in fact, even within the behavioral domain, you have specialists in different fields who stick to their own fields. I think, as we were having in a conversation last week in one of these workshops, you have the game theorists that do their thing, you have the nudge theorists that do their thing, you have other areas of behavioral science that do their thing. What we need to do is, I think, step back from the methods and focus on what the questions are, and then consider what methods are needed to answer the questions. And that's the point of attempting to put pandemics in this wider context here. So I see Andy Dobson's raised a hand.
Yeah, Andy, go ahead. I wonder if I have to release him somehow. can someone release Andy?
Yeah, I'm raising my hand. Does that work?
Yep, go for it.
So two questions, Chris, and I don't know. One is the St. Petersburg paradox. If we take Jess's $10, she could spend it on all in one, or she could spend it in 2 5s or 10 1s and decide on some frequency distribution of when she's going to stop. Are there different payoffs?
No, let me correct you on that, Andy. Sorry, and I might not have explained the rules of the game.
Okay.
You can only bet once. The decision that the player has to make is, are you going to join the game or not, and at what price are you going to join it? And you say, I've got $10, I put my $10 down. Now you toss your coins. So you just, the person tossing the coin just keeps tossing the coin. You say, well, this is what happened under these circumstances. You know, if it's tails first time, then you're going to lose. If you get 3 or 4 heads in a row, then you're going to win, but probably not very much.
I was thinking
there's only one decision to make: is will you enter the game or not, and at what price will you pay to enter the game?
I was thinking in terms of sort of vaccine development or response to pandemics. If you can hedge your bets across things by dividing your resources up, is that going to give you a better return than putting it all in one basket like the EEC? And that was partly one initial nerdy question. The other one was, did they use or have they used Sept at all for getting things for COVID? Was it up and running in time or just not available yet, as you said, Jed?
Yeah, well, Sept is integral to the COVID effort, as it has been to the effort to promote and develop other vaccines, including Ebola vaccine. What I can't tell you is precisely what their role is. They are named, I'm just a little bit too distant from it, they are named as key collaborators with WHO and Gavi in the so-called COVAX initiative. So that's essentially the insurance initiative that WHO wants everybody to invest in, and which the vaccine nationalists don't want to invest in. But exactly what their role is, Andy, I don't know.
I have a question from Brian Grenfell, who says, great talk, Chris. And he wondered if you had thoughts on how you prioritize development of a universal influenza vaccine, and the concept being that it could be more sustainable, so it might improve control of endemic seasonal flu as well as pandemic risks.
Yeah, well, I think the universal flu vaccine is, in the terms that I've been talking about, platform technologies, for maximum flexibility would be the logical and finest outcome of what's already going on. So what's already going on through the PIP framework and so forth is the sharing of viruses and information and precursor vaccines that can be readily adapted. But the perfect outcome would, if it's technically feasible, would be to have the generic vaccine, which was essentially the vaccine that you used for seasonal influenza or any pandemic that came along. It would really be the perfect outcome. So the question is, what you're essentially doing there is you're saying, with such a vaccine we can deal with any influenza hazard at all, and the risk of any influenza hazard is going to be very high. So you attach great value to that. The question from a technical and R&D point of view is, what would it cost in order to create a vaccine of that kind? But the argument ought to be, I don't know precisely what it is, but the argument ought to be, we'd be willing to invest a lot more money in that because the circumstances under which it would be used would be very wide. But everyone concerned with a generic influenza vaccine or any other kind of generic vaccine knows that argument well.
Great, that's a very wise take on it. I think unless there's any more burning questions, we might move on to our next speaker. Am I at the right timing? I think I am, right, Megan? So that's Jamie Lloyd-Smith. Thanks so much, Chris. And there's going to be more discussion at the end for the panelists. So